put the latest guidelines and recommendations on here, so this would be the way you practice, also in accordance to your supervising physician. So be kind enough to say, hey, I've got the latest recommendations if they don't do that, but otherwise you'll do whatever your supervising physician usually does. But I have the latest on there. Keep in mind again the years that those were changed and how many years our boards are behind. So I don't think they ever ask if it's annual or those kinds of things. I know they ask ages for colonoscopies and those kinds of things, and that will be on here as well. All right. So your lecture objectives: being able to identify, describe components of the history, review systems that are pertinent for your evaluation, so on and so forth, throughout the reproductive and postmenopausal years of a female. Identify and describe those components on the exam that's presented with your women's health issues. That is exactly the same sentence. Is it not?
Yep.
I just read that.
Medical history and then physical exam.
Obviously, I didn't read this the other day. So we combine lectures from previous years, and I'll fix that next year. All right, so obviously, and then the documentation accurately of what needs to be composed in that. We will give you examples. I have on D2L that Sally has put on there as well, a full write-up of a female pelvic exam that you can print out and use to your leisure. Recognizing and interpreting their history and physical presentation so that you can formulate your differential diagnosis, treatment plan, and so on and so forth. And then your focused gynecological exam thereafter. So if it's not their annual and you're not doing their whole body, they're just coming in for a gynecological complaint. We've already mentioned this, so as far as your female exam, when they are having a gynecological problem, we know that it is the external and internal genitalia of the vaginal canal, and then the rectal exam, as well as your breast exam. But a lot of people forget, I need to do my abdominal exam. You've already learned that, but that is certainly part of that. Anytime any female comes in with a complaint, they're not saying my stomach hurts, but if they're complaining of abdominal cramping, irregular menses, anything that has to do with the vaginal or rectal canal, you need to include the abdomen as well. All right. Here's just a list, essentially, of your review systems that go along with your female genital tract. We need to know from the beginning. How old were you when you started your periods? What was your last menstrual period? What's the regularity of that? How many days do your periods usually last? But a lot of the times, a female's not going to be able to go 28 days, 32 days. They'll say, well, I usually go the first week of the month, and then every 6 months it will change a week. That just tells you that it's usually a little longer than the 28 days. So you would just record in there 5-week cycle rather than a 4-week cycle, or 28 to 32 day cycle. All right. How long are their periods persistent? I usually ask, how many days do you bleed heavily, and then how many days do you bleed total? Some patients and females are going to be very, very in tune to their body, and they're going to go, I know when I ovulate, I know when I start getting moody 4 days before I start bleeding that I'm getting ready to start. Some women are going to go, I don't even know until I start bleeding. So everybody's different. Doesn't mean that one's abnormal than the other. It's just that what's normal for that female. And so when they ask, well, is that normal? Then I always say, well, that's normal for you. Is that any different than you usually do? And that's the basis that I go off of. Again, the amount of bleeding, that's the amount that's usual for that female. Any big changes. So the next few are our main terms. These are also ICD-10 codes that you can use. Metrorrhagia means that it's irregular bleeding, bleeding in between their normal period times. Can also mean just heavy bleeding. It doesn't have to be just spotting. So spotting or heavy in between periods in the irregularity is metrorrhagia. menorrhagia. Dysmenorrhea is painful periods. It doesn't matter if it's regular or irregular. Discharge, odor, irritation, we all know those terms, but those are all questions that you need to be asking. Regardless if they complain of that, you need to specifically ask those questions. And then again, have you noticed any rashes, irritation, lesions down there that is not usually there? Mass is going to be very uncommon, and that's usually not a good term to ask, but is there any bumps or lumps is usually yours that is. And then we're going into the actual detailed anatomy, the things that you're going to ask specifically about their genitalia. Are you sexually active? So you're going to have a different array of ages. Don't just assume that they're not, or don't just assume that they are. And then sexual orientation is a new thing that we need to be asking. Homosexuality, heterosexuality, I usually don't always use those terms. Reading your patient. So essentially, are you sexually active, and if it's a male, with a female? Or are you sexually active with a male? Are you using protection? And just follow up, because that's one embarrassing thing after the other. Just lump them together and get them over with. Okay. Then you can go into, and I usually don't lead with that. I don't know why I put this out, but so starting again, when was your last, go through your screenings, when was your last PAP? Have you ever had a PAP? The first PAP should be done at age 21, regardless of sexual activity or not. And then it is every year for 3 PAPs. Once they've had 3, and as long as all 3 of them have been normal, and there's no family history, then you would go every 3 years after that. PMS symptoms, again, go with your previous questions on your review systems. You would have already kind of figured that out. We've already asked about protection, contraception, and asking specifically what type. Sometimes I have older women that when I ask them, do you use any form of contraception, and they say no, then I ask them, are you trying to get pregnant? And they'll go, oh no, my husband has a vasectomy. That is still a type of contraception, so I document that. As long as she's not having sex with anything. All right, history of STDs and treatment. So I usually lump those together again up with the sexual activity and orientation. Are you using protection? Have you ever had a history of an STD? Have you ever been treated? Did you get the full treatment? Are you still symptomatic? Those kinds of questions will follow. Then again, if they're of childbearing age, how many children have you had? How many times have you been pregnant? That's 2 totally different questions. Some people have been pregnant and have miscarriages, so the number of times they've been pregnant is more than the number of children that they have. So don't just assume that they've been pregnant 5 times, they have 5 children. I always ask, how many times have you been pregnant? And then if they say 3, then I say, do you have 3 living children? That's how I ask that. If they say no, then they'll usually offer miscarriage or whatever. Yes?
The way I say it, I'll say, how many times have you been pregnant? How many babies have you delivered? Then you do some first grade math on your brain. And you have the number of abortions, whether it be a terminated pregnancy or it was a miscarriage. And then you ask, how many children do you have? And then you figure out from there. So I always ask it, how many babies did you deliver? How many times have you been pregnant? How many babies did you deliver? Then you'll catch multiples. Well, I've been pregnant 1 time. How many babies did you deliver? 3. She had triplets. So that's how I do it.
And then following that as well, I do Gravida TPAL. TPAL stands for term, preterm abortions, whether it's elective or not. Spontaneous is the other word for a miscarriage. And people that have had miscarriages are very sensitive for you using the word abortion, but that is the medical term for it. So you don't have to tell them that I'm reporting an abortion spontaneous. You just go along with what they're saying, and then just write it down that way. And then L is living. So I've been pregnant 6 times, almost messed up. It's like 5. 6 times. I've had no premature babies. I have had 2 miscarriages, but usually I would answer the living. So I had 4 living children, and then I've had 2 miscarriages that were spontaneous. So my TBL is 6024. Complications of pregnancy again, and that includes hypertension, pregnancy-induced hypertension. You'll learn a lot of these different things. Eclampsia, preeclampsia, all of those kinds of things. Gestational diabetes. And then if somebody mentions gestational diabetes, I ask them, have you ever needed to be treated for diabetes beyond that? And then I usually think of thyroid, because your thyroid can be messed up with pregnancy too. Sometimes they won't think of that, oh yeah, I was diagnosed with thyroid problems right after my last baby. And then, of course, if they're not old enough, you don't ask everybody about age of menopause, but if they're elderly, you ask them, how old were you when you went through menopause? If they're kind of in that variation of age, and again, it can be anywhere between 40 and 60 that somebody goes through menopause. My mom actually went through menopause at 38. Yeah, so I was worried about not being able to have children at 40. Those kinds of questions, because your patients are going to be asking you. And then dyspareunia means painful sex. I used to think that that was a question that you only ask elderly patients as well, because then that cues you into vaginal atrophy, the dryness due to the hormones being less and no more lubrication. But I've had patients being young coming to the ER complaining about pain with sex, and it's just different positions. You're going to get all different kinds of questions and scenarios. So does it hurt when you have intercourse? Those kinds of things. Libido and satisfaction, again, I usually don't go into this unless they're complaining about menopausal symptoms, hot flashes, night sweats, mood swings, irritability. And those can go along with depression as well, so you kind of have to differentiate the two. Yes?
How do you document menopause and hysterectomies?
So that would be post-operative menopause, or menopause secondary to TBSO, total bilateral salpingo-oophorectomy. So it's much easier, TBSO. But that's how I document it on the chart. And when somebody says that they've had a hysterectomy, I always say, do you still have your ovaries? They'll know, and they'll know whether they just have one as well. And they may not know which one, but they'll know whether they have just one or both of them still. So it's either a complete, being the TBSO, or in a partial hysterectomy. And then your review of systems with the breast. So have you had any changes with your breast tissue, not only with palpation, but with appearance? Any discoloration, any lesions, any lumps or bumps, any pain, any discharge? So self-breast exams we used to teach a lot. That's kind of gone to the side as well because of the fact that patients were being hypersensitive and wanting to have everything under the sun ultrasounded, and then ultrasounds were inconclusive, so then they were doing biopsies, and then those were inconclusive, so then they were doing more stereotactic biopsies, and even surgical mastectomies or lumpectomies that were still benign. It was just causing more and more stress and more false positives. So just make sure that you go through your guidelines and go with your supervising physician's practice guidelines. Last mammogram, again, the first mammogram it should be at 40 if they have no family history or high risk for breast cancer. And then, again, if they do self-breast exams, because you can still ask them, and then you would ask them those questions. When was your last and how often do you do it? And make sure that they were taught appropriately as well. Educating your patient's going to be key in that, because they're going to need to know not only their breast tissue, but what are the common lumps that you're going to find, and what are the etiology, or what causes, because there's tons of stuff in your diet that causes the fibrocystic disease and the nodules to appear. And it varies from different times of your period throughout your cycle. So that's another reason why it's really just, if a patient wasn't taught to do it the same time of the cycle every time that they do it, then they're going to have those inconsistencies as well. It's a busy, busy slide. Okay, so as far as your HPI, when we're talking about a patient coming in with irregular bleeding or abnormal bleeding, then again, the quantity is going to be how many pads or how many tampons are you having to use, because what one female might think is a ton of blood that she's losing might not actually be, or vice versa, because they've always been a heavy bleeder. Oh, I go through a pack a week. That's a lot. So how many pads or how many tampons are you having to use, or how often throughout the day? How many times in the middle of the night are you having to get up to change it? And then as far as your cramping, again, your big 8 as far as describing that. Is it a sharp cramp? Is it a dull ache? Is it a colicky? Is it waxing and waning? All of those things. Pelvic fullness, not only for bladder type symptoms, but even bloating and the sensation of your uterus being enlarged can be a complaint. Premenstrual as well as postmenopausal, as long as they still have a uterus. And then we've already talked about the intervals between your periods. Amenorrhea. So amenorrhea means they're missed a period. They've stopped bleeding. It can be primary amenorrhea, meaning that they're 16 and 17 and still have never had a period. Or it can be secondary amenorrhea. So they've already had their period, but now they've stopped. And the most common cause of amenorrhea in a childbearing age female is pregnancy. So if that's their complaint, you better do that pregnancy test to rule that out first, regardless of their history. I've delivered a 12-year-old that swore that she was a virgin, and she had a tumor. And even when we were in the delivery room pushing, she still said, I've never had sex. So they'll be in denial, and you just gotta work with them. Delivering the baby, she didn't hold it, and we were like, oh, you need to name it and raise it. Her mom was actually making it worse because she was, oh, she's never had sex. She lives with me, and she's never had one. I'm like, her name's not here. So you'll get all sorts of that. And the biggest thing on that, if you have a patient that is in denial and they don't have a support system that's in reality as well, you've got to think of the safety of that baby. So you need to be making sure that you're following up that mama and baby very closely and making sure that she's not having postpartum depression or any symptoms that she could possibly be harming that baby. Do tons of educations, use your, yeah.
So what would everybody want to know if you're taking care of a 12-year-old who says she's never been pregnant before, about that 12-year-old?
So she abused, does she know what sex is?
Has she been sexually abused? I mean, that would be my first. You start asking those hard questions.
When the mom's not in the
When the
room.
mom's
So this is where I pulled I'm a PA and that's my supervising physician's job. No, we got him. She's pregnant, she's still denying it. She's yours because you get to deliver her, because she is in here complaining of abdominal pain because she's in active labor. And I took care of the babies and his job was to deliver them. So I was like, hey, Dad, you're it. Kind of laughing background, watching him sweat a little, but yes, definitely cover that. Because she, in her mind, she hasn't had sex because she was assaulted. Yes?
What are the rules and regulations for asking an HPI for an underage?
In the state of Oklahoma, when a female is pregnant, she is no longer a minor. She is an emancipated adult. Absolutely. So all of that goes out the window. What? Sarah's like, what?
I've been here like my whole life. How did I not know that?
You were never pregnant.
That I was not.
Yep. So, know that because they'll come into your ER, and so then immediately, especially when you've got these mothers that are either trying to hide something because yes, they were abused in their own home and she allowed it, or other reasons.
Or she's profiting from selling images on the internet, because that happens a lot.
Really?
Don't think for a minute it does not. Parents will do that to their own children
Yes.
and profit from
Crazy.
child
There's
pornography.
some crazy people out there, get ready. The other interesting delivery that I had, the child was 15, and again, I did peds attending this because I was practicing in Blackwell, small town, and my physician did pretty much all of the deliveries, even though he wasn't in the league. And so I was there for all the deliveries to take care of the baby once it came out of mama. And we were ending up, we started her delivery, the 15-year-old, and he said, and by the way, her mom's across the hall. And behind closed doors, a little bit more insight, he said, the daddy of both babies is the same person, which is mother's boyfriend. And they're okay with it. Yeah. So he was like, we've got a little bit of family dynamic problem here that we will resolve afterwards, but this is what's going on, and I didn't want you to walk into a mess because he'd been taking care of both of them prenatally. And of course, I show up for the delivery and didn't have any of that information. So he was like, okay, we gotta talk about this before you walk into a mess and step in it, because I would have big time. Yeah, that was a little awkward, both of them. So that meant, I was like, so you got pregnant on the same night, or at least, yes. Very weird. So you are going to encounter some very, you can't make this stuff up. Really. Yeah, no. You'd be like, okay, doctor's call, be right back, and you'll be walking out. I gotta gather this myself before I go back in there and start asking questions. So, just know we've got to get the stuff to take care of them appropriately and make sure you get all the information. So as far as vaginal discharge, if that is their main complaint, you're always going to want to know what's the color, what's the consistency, is it every time? Is this normal for you, or is this more than normal? Does it have an odor to it? Are you having not only just the discharge, but itching or irritation, or what other symptoms are you having with that? Are you having abdominal pain? Are you having pain when you're urinating? Does it feel like it's in the vaginal area, or is it on the external genitalia when you urinate? So I try to explain those things and ask those detailed questions so that I know what to expect, or kind of think that I know what I'm getting into before I do my exam. That'll help you prepare for whatever specimen stuff that you need to have ready when you do that pelvic exam. So, do you use other hygiene products such as douche? Do you use lubricants over the counter during sex? Do you have to use a lot of perfumed powders or anything like that? Those are good questions to ask as well, because that's going to help you to educate that female on how to improve to prevent whatever it is that she's got going on. All of those types of products usually alter your pH and your environment of the vaginal canal. Obviously, you're going to want to know what her sexual history is. So are you sexually active? Are you using protection? So even if they are using a condom, they can still get an STD. So not only are you having sexual intercourse, not just penile penetration, but are you having oral intercourse? Are you having digital intercourse? Are you having intercourse both vaginally and anally? Those are the kind of sticky, uncomfortable questions that we've got to ask. Obviously, reading your patient again, I've just got to ask some uncomfortable questions so that I can take care of you the best way possible. And I need to know what are all my possibilities of what's going on here. So then we go on to, are you on any medications? Is she currently on birth control? Does she currently have an IUD in? Is she using any other devices, whether it be the NuvaRing or are diaphragms still out on the market?
Yeah.
Does anybody know what I don't know if I'm saying it right, a pessary device is? So your older women will use those, and that's usually when they start having pelvic floor dysfunction. So when their pelvic floor, whether it's just from old age or from having multiple kids, because older generations had 13 and 15 and 17 kids, those muscles deteriorate. And so then all of your internal stuff starts to fall out. And so a pessary is just a device that kind of held that stuff up in there so it doesn't come out with the vaginal. All right, lovely stuff to get into here. Premenstrual syndrome. So again, you guys, being female, are going to have an advantage of knowing what to ask specifically, but some of us didn't have all of these. So headaches, mood swings, cramps. How debilitating is that? Do you have to go home from school or from work? What kinds of medications are you taking? Are you taking over-the-counter medications? Are you having to go get a prescription? Are you having to go to the ER and get a shot? How severe is it? And then does it happen every time, or is it just once or twice a year? How often? So all of us feel bloated. There's a little bit of weight gain, but that can be day to day, but how much of that is going on? And then sometimes they can also get diarrhea along with that. And I know I don't have it listed up there, but that is common also because of all of the stress and hormones. Some females just get anxiety-driven diarrhea as well. Your menopausal, we've already talked about that. So age can be anywhere from 40 to 60. Usually they hit it before 60. Their bleeding is going to become inconsistent. It's not just going to be that they stop bleeding and then they get hot flashes and all that. Sometimes it starts out with really, really heavy bleeding and clots and tissue and a lot of pain that they have not had with their periods before. And then they'll stop. And so you have to know what's been going on so that you can utilize hormones to potentially stop that bleeding if it's really, really heavy. Checking them for anemias because if they've lost a lot of blood and now they're fatigued and they're dizzy, they're passing out. Being able to make sure you're thinking of everything that symptom is causing. Self-image. A lot of women obviously are beyond their midlife crisis, but then this is another milestone. And then sex. Are they having sexual intercourse? Is it causing you a lot of pain because of the dryness, because of the hormone that you're no longer producing? It affects the glands from lubricating that area. And what medications have you tried? There's a lot of herbal stuff out there now. Not only teas that they drink, but topical creams and herbal stuff that is out there on the market. So ask what it is that they've been using so that you don't double up on that by giving them a prescription with estrogen or turmeric cream. Then we have the whole big bucket of infertility. You're going to have a lot of anxious females. I know that we've encountered one at Good Shepherd already, somebody with me a couple weeks ago. Yeah. Very, very young. She was like documenting everything under the sun, every time she had a bowel movement, every time they had sex, every time she had a period, and I mean, it was ad nauseum, everything was documented. She really has not had infertility yet, she just hadn't gotten pregnant when she wanted to get pregnant. So a language barrier there, so that was a little difficult. But infertility again, so have they already been to an infertility specialist? Have they already had problems? What makes you concerned or think that you are having problems not being able to get pregnant? When was the last time you got pregnant, or have you ever gotten pregnant? When's the last time you've had a period? Are they regular? All of those questions again. Usually being infertile is not even considered unless they have consistently tried accurately to get pregnant for 12 months and not conceived. Asking them, do you know of any abnormalities that you have? Do you have polycystic ovarian disease? Do you have diabetes? Do you have, is that all of that, whether it's diabetes insipidus or mellitus? Do you have family history of any abnormalities with infertility? Low progesterone will sometimes cause not being able to carry a viable pregnancy. So whenever I started having my first miscarriage, my physician sat down with me and said, you know, a lot of women have had miscarriages and not known it because they were pregnant and miscarried before they even knew they were pregnant. Going through all of that and learning more about their cycle and their hormone levels and what type of problems they're having will help you to kind of educate them on the possibility of getting pregnant before you send them on to a specialist, or even if they need a specialist, because it might be something as simple. My miscarriages were caused from my progesterone level just being too low. And so I could get pregnant really easy, I just couldn't carry it. So the first one was at 14 weeks and I had to have a D&C. But then my second one was at 8 weeks and I barely even knew. It was just because we were trying and paying tiny. I wasn't documenting as much as she was, but I was documenting. So usually at 8 weeks or 6 weeks, you really don't know you're pregnant unless you know what's going on. But then he put me on progesterone cream. That wasn't enough, so then we used progesterone suppositories, and then that helped me to keep cold. So that was a viable pregnancy, and then I was done, so I didn't have to do that anymore. So it might be something as simple as that, and I didn't have to go to an infertility specialist and pay all of that money and have all of those tests done. Age obviously has a lot to factor in as well, because that changes your hormones. So your hormones can have a huge effect on the viability of a pregnancy and fertility. All right. Nutritional status, obviously, too. So if you are having a patient that is bulimic or malnourished because they're not eating healthy, or they are a runner and run all the time, that affects their hormones and a lot and can affect them being able to get pregnant. Being on drugs, obviously, and being malnourished, or being an alcoholic, being malnourished because of that will cause effects of your hormones as well, being able to get pregnant. So all of that goes into effect. And then urinary symptoms, again, we've already learned that in GU, you've had urinary already. This just goes into more, we've already covered all of this, sorry. You didn't follow my slides, I just went and did. So all the details there. Make sure on your obstetrical history, again, any type of complications. So if they went into preterm labor, I had a complication with my first delivery. She got stuck at her shoulders. Her head came out, and every deliverer I'd ever seen, the baby crossed out after that, and she wasn't coming out. And I'm like, this isn't going the way all the others were. Mine was the worst delivery I'd ever seen, and that's still to this day, other than known complications with C-sections. But so shoulder dystocia is what that's called. Just my hips don't spread enough. And so then every baby, and she was my first, after that, we induced all of my other children. Because she was 7'7", really not that big. My hips don't spread wide enough for them to come out. There's different maneuvers when you have a baby stuck, and if you go into OBGYN, you'll learn that, but with every maneuver, it's a greater risk. There's 4 different ones, and we went through 3 of the 4. The 4th one usually causes the baby to die, the mom to die, or both. And I did not know that until my 1-month follow-up, and then my physician taught me, so I was glad I didn't know that. Anyways, so you've got to know what are those complications so that you can plan ahead and treat your patient accordingly if you're going to do OB, obviously with that. Preterm labor, sometimes people go into preterm labor because their blood pressure is too high or they have preeclampsia, and those are very important for you to know. Multiple pregnancies, you'll definitely document that as well. And then any complications with the baby thereafter, I usually put in the mom's chart too. All right, gynecological history again. When was your prior PAP? Now they do HPV testing, so usually if you've had an STD or you've had an abnormal PAP, it would flag and reflex at the lab to go ahead and be tested for HPV. Now I'm not sure if they just automatically already test that or not. That's again a protocol that you'll have to check with whoever you work for on whether or not they're checking for that. HPV, human papillomavirus, is very, very common, but it's also the precursor for cervical cancer. And so abnormal PAP results have evolved through time as we've learned more. Carcinoma in situ, it used to be just, they would call a dysplasia, and then they would stage, whether it was stage 1, 2, 3, and 4 dysplasia. They've gotten more aggressive with that and knowing. How many of you have read Henrietta Lacks, or The Immortal Life of Henrietta Lacks? So that helped us know a lot about this virus, as well as the actual advancements with pathology, reading and pathology reports. I learned just in the past 2 months from reading that, the changes that occurred. So I don't know if they call it dysplasia or ask us, because I don't do GYN anymore. We've done that in many years, so we'll have to look into that. Procedures, so there's stuff like the LEAP procedure. If you have an abnormal PAP and you have to do a biopsy, there's an actual microscope that's used during a pelvic with the speculum to do a punch biopsy of that tissue on the cervix itself. There's cryotherapy, which is burning, coning, which is actually shaving layers of the cervix. Different things are done depending on the depth and the degree of the dysplasia, which is the abnormal cell growth. All right, STI or STD, sexually transmitted infection. PID. PID is just a combination. It can just be bacterial vaginosis, but it can be a combination of VV and an STI. PID usually, I explain to my patients, because yeast and VV have very similar presentations. Both of them cause itching, both of them cause pain with urination, both of them cause pelvic pain. When you've got PID from bacterial vaginosis, your sexual intercourse is usually a lot more tender because of the impact of when you have the chandelier sign and the pain with cervical movement. And then a yeast infection itself usually doesn't cause that. Cancers, and then diabetes. Diabetes just due to the fact that when your blood sugars are high, you're going to be more apt to getting yeast infections and other infections in the vaginal canal due to the pH changes from the sugar being so high. All right. This is the same past medical record as any of the other, so that's not any change. You know all of that. Medical history, again, this is usually with your older patients, but when you've got a female, whether they're postmenopausal or perimenopausal, really doesn't matter that, but when they've had a lot of children, you need to be a little bit more intrusive with your questions as well because of that pelvic floor dysfunction. Are you having urinary incontinence? Are you having fecal incontinence? If they've had a large tear and it wasn't repaired correctly because they had a complication during the delivery. So with the shoulder dystocia, I had a 4th degree tear, which means that they cut, but then I tore all the way through my rectum. So that whole perineal area was just a mess. And you had to sew all of that back up. That obviously changes the anatomy of your anal sphincter and the function of that. So those are important questions to ask. Did you have an episiotomy? Did you bear? Do you know what degree? Those kinds of things, especially if your patient is coming in with the chief complaint of rectal incontinence or constipation or hemorrhoids. And that ties in with sexual practices and satisfaction as well, because if she's having a lot of pain because of the scar tissue that developed from the tear, that's where you can educate them as well, or even refer them on to get some help. So now they've got vaginoplasties, is that how you say that? To where they can go in and correct some of that. But again, that would be a referral. All right, your physical exam, same-o, same-o. We've already covered all this. Those are just your vitals. So your blood pressure is always important, and then the lymphadenopathy, thyroid, of course, because that goes hand in hand with female hormones. Your breast and axilla, so your armpit is breast tissue. All right. General considerations, obviously, before you even touch your female patient, you've already talked to them for quite some time, but still, she's going to get undressed. You're going to explain to her the procedure. We're going to do a pelvic exam. It's going to encounter a speculum, show them the equipment, especially a young female that's never had one before because they're scared to death. I had my first pelvic at 18 because back then that was the protocol. Every child at 18, regardless if they're sexually active or not, had one. And I was never told any of this, and so I went in blind. I was an old doctor. And by the time we got to my bimanual exam, I had no idea he was going to do that, and it freaked me out. So tell them everything that you're going to do. That will ease their mind and help them to relax, as well as not be so flustered before they even get undressed. Showing them the equipment, telling them what you're going to do, telling them that you're going to use the speculum first to get the specimen, and then use your fingers to be going intravaginally. Because by the time they're 21, usually they don't have into that. So it probably won't happen as much as back when we were doing it at 18. But still, I still have students that are going to college here that are coming in for their first time and they are scared to death. So explain all of that, and that helps. Even after you explain, obviously, you're not going to stay in the room when they get undressed. I always say, just get undressed from the waist down. You can keep your socks on if you're always cold, that's okay. I'm going to give you a drape, so whenever I come back, I just want you, and you'll put a blue pad on the table, sit on the blue pad, and then just have that draped around you, and then I'll help them get into position. The nurse should be well trained for you on what specimen stuff that you need and have that all set up, but sometimes you're going to be in a new clinic and they have not been trained for that. So make sure in your head you're playing through what are the steps and what do I need so that you've got everything out and ready, and you're educating your nurse what they need. All right. Before you actually start doing the physical exam as well, you're always going to tell them, I'm going to touch the outside of your legs first. I'm going to have gloves on. I always have my patient literally, because anytime they are sitting on the table, their bottom is forward, and when they go back, then inevitably they always go way back here. And when you try and put the speculum in, you're going to hit the table. So once they lay down, I always stick my hand like this, my left one, because it's not the one that I'm going to be using to do their vaginal exam, and say, scoot down until you can feel my hand. That way they're on the edge, and I'm not having to worry about my speculum hitting the table. All right. Maintaining eye contact. I don't maintain eye contact when I'm doing the bimanual examination because that would be really uncomfortable. But I am looking towards them so that I can see out of my peripheral vision if they're wincing or if I'm hurting them.
Now, eye contact would be super awkward.
Very, yeah. So I'm going to change that because that's weird. Does that say maintain? It sure does. As appropriate, there, for your patients. I have never known to look at me in my eyes when you're doing that to me. No. So, talking to them calmly, telling them ahead of time. While you're explaining that, that also shows you how anxious they are to that. I've even had an older patient at Good Shepherd that she was married and had children, but she, before we even got started, said, you need to use a really small speculum because it hurts really bad and it's always just really tight, and my husband even complains. And so I'm like, okay. Didn't really think, I did get the smaller because these come in different sizes. I did get the smallest one that we had there. And then when I introduce the speculum, I don't introduce it this way because that's wider. I introduce it this way. Naturally, our slit is longer rather than wider. And that way I could tell how much resistance when I was turning this, because I'm not trying to hurt her. She was really, I mean, I was really surprised because she was in her 40s. So when I introduced the speculum, again, I introduced it sideways, but I also tilt it down, because almost always people's cervix are not like this, they're like this. And so if you introduce it down, you're going underneath and then lifting and opening it. Because it's frustrating to you and the patient if you're in there digging around trying to find that cervix, and all the time you're on top of it, you're never going to find it because you just keep doing this. Okay. So that was the best piece of advice that I could ever give anybody, because when my supervising physician said, tilt it down as much as you can and then go up, then I started being successful, and I was like, oh my gosh, that's so much better.
I'm going to show them on this too, because you look at the cross-sectional anatomy, like, it's, let's pretend like this is the vagina. I mean, it's like this. So if you're putting the speculum in this way,
Here you're going.
right on the ram in the top of the vagina, right? So if you tilt it down and go down and then lift it up, it'll bring the cervix into the, you can see it. Does that make sense? Yeah. So yeah, if you go straight in, you're gonna hit the superior wall of the vagina.
And you're never gonna be able to
Maybe
find
some
it
of you
if you're on
have
top.
had that experience before, I don't know. But
It's not even.
if you've had this uncomfortable pap or pelvic before, it's probably because they did not insert it downward. Yeah, there you go.
So if you remember anything from this lecture to do a pelvic, do that. Make sure it's down. Go ahead.
That's two important things. That, don't forget to close it before you pull it out.
Oh.
Two simple things. But the men will not know because
They've never been pinched.
they're not here.
So I don't close it all the way because I'm always scared of pinching somebody. But I do. I close it and I look as I'm coming out slowly too, to make sure that the walls aren't like invaginating inward. So you are going to have some very difficult morbidly obese women that they make really long ones too. But I wish, and I've tried to devise, but I just don't have money to pay an engineer to get a 4-sided one that does this number. I've had to at times.
They have them.
They have them now.
It's purple, is that what you said? Like,
No, metal.
oh, I think it's purple. I was like, interesting choice.
I don't think they got used to that.
So I've had to literally, this one doesn't do it, but some of your speculums, we have different
I can,
kinds.
that's just that box.
Okay.
I can run up and get it.
That's okay. Some of them you'll click like this, go up, but then some of them will actually literally raise to open this wider too. Which is good because the ones that are morbidly obese, it kind of stretches this to where this goes this way, where you can see. But I've had patients literally to where I'm like pushing really, really hard and having my nurse put their foot behind my wheel because otherwise I'm like this, sweating, having this in place and then having tongue depressors that I'm like whittling in there and with my spatula, so I'm like one hand trying to do these numbers. Yeah, it is a mess sometimes when you get in there, so just be ready. And I'm sweating to death and I'm like, so just be prepared. Get all your tools that you might possibly need. Get the right size speculum will help you tremendously. The one that was really, really tight as well at Good Shepherd, whenever I tried to introduce that, I mean, I was meeting so much resistance that I was like, this is going to hurt her so bad. So I literally, and this is the first and only time I've ever done that, stuck my finger underneath it and was pushing down and just talking to her to relax. And once I could feel her relax those muscles more was when I slowly, and she afterwards was like, that was, didn't say that was the best I've ever had, but at least amount of pain on a pelvic exam. So listen to your patients and don't just go, oh, she thinks she's dying. Test it with your fingers if you need to, so that you are not hurting them. Because one, you don't want to tear them because you're going to have to fix it or refer her to out, which is not fun. And you want the best specimen, because if you've got a lot of blood on that, it's not going to be any good either. Okay? All right, moving right on. Those are just key points in actuality. Got way off there. Where am I? So, patients' anxiety and discomfort. Listen and follow accordingly. They know their body. Obviously, no sexually suggestive language. That's more so for men. But reading your patient, doing what's appropriate. Don't play along with them either, because even if they're joking and you get into that with them, they might at one point in time go, oh, you crossed the line, and then you're in trouble. So just refrain from making jokes. You can not tell them that they're being vulgar, but just move right along. All right. Talking before you touch, I'm touching you on your thighs. If you can just relax as much as you can. And I'm going to literally touch the external genitalia so that I can see everything to make sure that you don't have any lesions. Because very rarely as a female, sometimes you'll get them in with a mirror and everything, but will they look at every orifice and every fold? So that I can treat you appropriately for everything. So you're spreading and looking at all of the anatomy. Obviously, we know, wash your hands, use gloves, warm your hands. Yeah, my hands are always closed. Well, cold, doesn't matter if I use hot water, it's not happening. Make sure you have a chaperone, so when you're explaining to them what you're going to do, you say, I'm going to bring the nurse back with me because I have to have one in here because I need more hands, but then also for documentation. I actually later decided that that was unnecessary to explain that, so I always just said, because I need more hands, which was true. All right, already talked about making sure you have all your supplies, making sure you have all your equipment. Try to minimize your nurse coming and going when you've got that patient. You guys have been there, door opening, closing, not happening, not comfortable. All right. Gown and sheet would be great, but usually it's a little piece of paper. When we did our practicum, when I was in school, we were like, Kleenexes, here, go put that on and tell me that, because that's what you feel like. You're like, we need tape. Kleenex. I'll need that. Proper lighting. Wonderful invention was when the lights went in these things. It's great, because now you don't have to bobble your head, but you're going to encounter that probably, especially if you go rural. They may not have the lighted thing. Check your light before you start either, because it does you no good if it's not working. All right. We've already talked about positioning, pillow, making sure they're comfortable, and making sure that your speculum's not going to be hitting the table. All right. These are the ACOG guidelines for your mammography and breast examinations. Again, it goes off of family history and their risk, and then their age. So make sure you know this chart for this class. As far as for your boards, this recommendation, I will get the date, but I'm pretty sure it's fairly recent. I remember going to the CME conference, I think it was 5 years ago, when they first started announcing this, and you could hear the whole room going, because they were like, we're no longer doing self-breast exams, and we're no longer even doing mammograms until they're 40, and we're like, the people that have that gene are dead before they're 40. So that was the whole big argument in that class. But again, it goes off of their risks, so know this. On your inspection for the breast is 3 different positions. So them sitting normally, them putting their hands on their hips, and then also them leaning forward. You want to not only visualize them from the front, but also from both sides. Because I can't see the sides of my boobs, and I'm assuming that you guys can't either. So make sure that you are checking everything that they can't see. Asking them, is there anything in appearance that you've noticed to be different? I don't always say abnormal, I use the word different. Nipples especially, because some people just think that, oh, my nipples are just changing because that's an aging process. Not usually, especially if it's unilateral. Be more heightened and flagged if it's a one-sided change. All right, so these are some of the changes that are very specific to be concerned with and to be watching for. That's why they have names. So Peau d'Orange is literally the skin is dimpling like an orange out covering of an orange, the fruit orange. It's due to the fact that the skin is thickening, and then the ligaments that suspend the breast tissue are also being pulled by underlying masses or nodules. Paget's disease is specifically a ductal cancer, so the mammary ducts are involved. And again, that's where your suspensory ligaments are going to be involved quite a bit. But they'll start having a literally red, so if you see this on your boards, red scaling, crusty patch on the nipple or the areolar area, think Paget's disease. And then just dimpling, whether it's one big dimple, pay attention to it. We don't develop, we develop dimples in utero on our face, but we don't just nonchalantly develop dimples on our breasts. That's going to be something that you need to be paying attention to. And it may be really, really small in the beginning and then continue to grow. But that's something, if you see a dimpling and they've never had it before, make sure you're getting a mammogram. The ligament of Cooper is a term that you need to know and remember. Here's pictures of those disorders. So the Peau d'Orange, Paget's disease, and then that is more anatomically of showing what's underlying the mass that's suspending and pulling on that skin, making it dimple like that. All right, so we've already talked about breast appearance, not only contour, but symmetry is going to be extremely important. If there's only one breast that's making a big change, then you need to be very heightened awareness and make sure that you're following that closely and working that up to the best of your ability. The nipple, again, so if they're starting to have a nipple inversion, especially if it's unilateral, be concerned about it. Some people, though, are born with more than just 2 nipples. And the diagram over to the left shows kind of the areas of possible other nipples that would be normal anomalies. But again, they're going to be born with that. It's not something they're going to develop later in life. Yeah, that's unusual. I've never seen in practice yet. Somebody with extra
You can see them. Let me know.
No, not today, even though there's no guys in here, I'll show me. Show me. All right. So, nipple discharge. Nipple discharge, especially if the patient is complaining about it and they're not trying to get pregnant, or they're not currently pregnant, or they're not currently breastfeeding, because sometimes you've had a female that are breastfeeding up until the child's like 4 and 5 years of age. So those are the questions that you ask. And then obviously too, how much of a discharge, what is the color, is it from both nipples, so on and so forth. Document all of that. Is it tender with that nipple discharge? Is there blood composed in with that as well? Does it have an odor to it? Kind of the same questions with the vaginal discharge. You would just follow along with that suit. So Montgomery tubercles are very, very common. It is a normal variant in the areolar area. Kind of initially looks like just a pimple or a papule, but it's in the areolar area. And they can exude some clear as well as milk coming from them. It's usually not a whole lot, but it will. And a lot of patients will go, well, I've had this pimple and it doesn't get red and it doesn't hurt, but it won't go away. Those are just Montgomery tubercles, and just that's just a variation of your areola. Stop picking at it. It's fine. It's not anything to worry about. It's not cancerous, benign. And, you know, it's not something that you're born with. These will develop later in life. So I've had these, and when I did this lecture, I was like, oh, that's what those are. Okay. Now I know they're normal. I didn't know anything about those. And I didn't really develop them until my 4th child, so I don't know if it has to do with more times you've been pregnant or not. But okay, lymph nodes on palpation, obviously you're going to do the cervical, supraclavicular being the most important, but then your axillary nodes with your breast exam. So when you're doing your breast examination, you're doing the 4 quadrants of the breast, the upper outer quadrant of each breast being the most important one. That is the tail of Spence. But then you're also going to do your full axillary node box examination that you've already learned. Breast examination. I've not done a breast examination on anyone other than in the supine position. I do an observation in other positions, but I don't do a breast exam. And I know that this lecturer tells you to do it within setting up and laying down. I would just do it laying down. Always, whichever breast you, so if you're looking and palpating the left breast with them supine, you have them raise that same arm. And you just have them relax. And then you do the movement. Arm overhead, supine position, that way it stretches the tissue out, and then you develop whatever pattern that you want to go in. It's the same every time, and you'll teach your fingers to see. So this says in a rotary motion. To me, rotary is like this. I don't do that. I literally, so these are your choices. Right here. So it's showing up, back and forth, and then round. I do the, what's that called? Does that say wheel? Wedge. Wedge. I do the wedge, but I do it opposite. I guess I just can stand top. I actually go from the outer to the inner, bringing it towards, and then filling. So you're using all 4 surfaces of your hands and bringing it towards me so that I'm seeing if there's any density nodules. And so I do all of that all the way around. And so like if this was her left breast, do all the way around and then really do that top quadrant, outer quadrant again. As long as you are consistent and don't miss any areas, it's not wrong. Just make sure, again, that you are palpating fully with your hands. So I do the topical like that, but then before I try to express any nipple discharge, I also feel the density and use like the breast tissue, push it in between my hands and try and feel this way too, because sometimes deep nodules aren't palpable until you do that, and then I try to express. So this is not a nipple, but yeah, cervix is not a nipple. So squeezing that, making sure that there's not any, because some women don't touch themselves and they would never know until you did it, and then they're like, yeah, I guess I do. So don't be shy, just let them know. I'm gonna try to express any milk from the nipple because that's not normal unless you're pregnant or breastfeeding. That shows right there the position of your fingers with the nipple discharge. And I'm just reading through this to make sure. So always making sure the complete breast tissue all the way up to the clavicle. I don't think that I've gone that far, but some women are well endowed, you would go up that far. But the corner, I always go all the way up into their axillary area. Again, note tissue consistency, elasticity, nodules. Indurations means a raised area, so like a will or urticaria, like a rash, is raised. So anything that you can turn to the side and see that is raised above the surface, that's called induration. So when you're reading like a TV, that's what you're looking for. Not only the redness, but you're looking for induration. Obviously mass and tenderness, and then you notate that. And again, on the breast tissue, you use it like a clock. So I've noticed a nodule to be a soft, I would say like moderate tissue density, not hard like a rock, but not soft fatty adipose tissue. So moderate density is a word that I would use, measuring, and you would use your fingers to try and determine the borders. Well, consistent borders, mobile or non-fixed underlying structures is a bad thing. A hard marble-like or rock-like structure is not a good thing. Non-tender is sometimes worse than tender, so notate all of that. And then notating the appearance of erythema or anything like that also. The size, definitely, less than 0.5 centimeters, 0.1 or 1 centimeter, so on and so forth. All right. Already talked about all of that. So breast abnormalities, the most common is going to be your fibrocystic disease. A fibrocystic disease are benign cysts that develop in the breast tissue. Most women that have it are going to have it bilaterally, and it changes as far as the number of fibrocystic nodules according to their time in their cycle. They are mobile, which is extremely important that you notate that. They can be tender and painful. They're not going to induce or cause discharge though. Fibrocystic disease is increased with caffeine use. So then you're going to start getting that history. How much caffeine do you drink? How many cups of coffee? What's the size of the cup of the coffee? How many pops? How much tea? So anything that has caffeine. You drink Red Bull, those kinds of things. All right. Fibroadenoma is, again, a benign neoplasm. This one is usually bilateral also and mobile. So I can't tell just on palpation the difference between fibrocystic disease and fibroadenoma, other than the fact that if they say it doesn't change throughout their mitzvah. So if it's staying consistent throughout their whole cycle, that would kind of clue me in. But again, they feel kind of the same to you because you're not with them all the time knowing that they're changing, and so you're just going to do an ultrasound or a mammogram. And then your malignant breast tumors, again, usually unilateral, but not always, fixed, single area. You're not going to be able to get your fingers all the way around it and move it around. Sometimes the borders are not going to be well defined as well. It can be surrounded with fatty tissue that's just interlined with that. So usually non-tender, we've already talked about that, and does not change according to their cycle again. Gynecomastia is just the enlargement of breast tissue, can be male or female, can be caused by pituitary tumors, liver failure, so people that are chronic alcoholics or have some other type of liver disease, hepatitis in any form, end stage. Medications, what medication causes gynecomastia? Spironolactone. And then pot smoking, which I didn't know, but now I think about it, I'm like, maybe you could diagnose it. Oh, you smoke that. Do you take spironolactone? No. Okay, then it's not that. I don't know the etiology behind that, but I'm going to look into it now. That's interesting. Galactorrhea, so causing lactation, and again, men can have this too, but almost always, if it's not associated with being pregnant or breastfeeding, then it can be caused by medications or prolactin secreting tumors, and then hypothyroidism. Mastitis. So this is inflammation, infection of the it's not mastoiditis, I can't even think of it. What is that mastoid? Mastitis. What is the term for that? Lymphatics. What is the word I'm looking for? No. The system. Mammary. I'm way off. So your mammary ducts. So when you're breastfeeding, they can get clogged. And so then you develop a discolor and an odor within the milk. You're still producing milk, but it's getting clogged, and that's very, very, very painful. And those women can get very sick very quickly. Their breast can be bilateral, but usually it's unilateral. Usually caused by a staph or strep that's on our skin always, and then when the baby's feeding, then they get dried nipples and they crack, and then the bacteria gets within the mammary ducts that way. It's not customary that you make the female stop breastfeeding, because a lot of the times that affects their production of milk, and a lot of moms are very, very particular about that bonding. So you can still breastfeed when you've got mastitis. It's not very comfortable, but you get them on an antibiotic, obviously, that is safe with breastfeeding, and then you have them use ice packs and a cream to soften that so that the cracking stops, and then that gets cleared up. But most commonly it's from breastfeeding women. You can get mastitis though even when you're not breastfeeding. It's not as common, but you can. So that's also going to be on your differential if you've got a unilateral breast that's tender, red, and swollen. They'll run high fevers with that. I actually got mastitis with my first one on Thanksgiving Day, so nobody was open. 104 temperature, shaking, couldn't get comfortable. Had to go to the clinic and get samples of chewable augmentin because that's all we had as far as the samples. Nasty. You can swallow this, by the way, you don't have to chew them. Didn't have to. It's nasty and it stays in your mouth. Okay. External genitalia. Mons pubis. So knowing your anatomy, you don't have to go, I'm going to palpate your mons pubis, your labia majora, minora, clitoris. You don't have to obviously not do all that. But these are the things that you need to be checking. Most commonly, sometimes they'll develop an abscess. Is going to be the Bartholin's gland, which is the lower border of the vaginal opening. So here's a picture, if you don't remember all of that, because anatomy's been a few days ago. Couple. Perineum is the same on a man and a female, just the tissue between the vagina and the rectum or the anus, whichever word you want to use there. But our perineum also has a complete layer in between the vagina and the rectum as well, that wall. Some are thicker than others. All right. So this is a no-brainer, making sure you're just draping them, allowing you to be able to see that you're not just having them lay there without any clothes on. Covering their knees and then pushing the drape down to where you can see their face but not staring into their eyes, so that you can see their wincing or how much pain. The other thing is when you're doing your bimanual, I don't go on top of the paper because you can't see as much, so you're just going to tell them I'm going to be pushing on your stomach from underneath the paper here. And that way you're pushing and pulling the uterus towards your fingers to be able to size that uterus. I almost took this off because this is a no-brainer as well, but I guess I must teach it. Don't force your way into somebody's legs. All right, if they're that uncomfortable, then you can say, let's just talk about it, and you read about it, and you come back another day when you're more comfortable, we can talk again, whatever we need to do to get you to that point, but then explain to them why it's important to do those screenings. All right, I'm not going to go through all of this. This is stuff again. So when you're looking at the external genitalia, obviously you're looking for any rashes, any discoloration, any lesions, any masses, any signs of infection whatsoever. The labia minora will also can or do not have to, but they'll be erythematous and have caking with like a yeast infection. But you'll definitely have that discharge intravaginally. Sorry. The white discharge is more sometimes described as a thick or cottage cheese discharge, whereas bacterial vaginosis is more of a frothy, thin, grayish white, but malodorous. Sometimes you can smell it when you walk in the room and you don't even need to go in between their legs. Those are the good ones, because then I'm like, yay, I don't have to do that. I already know. Okay. I've never documented the size of the clitoris. I don't know if that's important. It might be for like a pediatric patient that you're suspicious of sexual abuse or anything like that, or for trauma, so like a little girl that's riding her bike. Any of you ever done that? Or riding a boy's bike and he fell in the dark? Don't feel good. So those kinds of things, obviously. Then you would notate it. Sometimes elderly patients as well, when they get an infection, it will swell because the clitoris is right above the urethral opening, the orifice. So all of that's irritated. But enlargement may be a sign of masculinizing conditions. So if you've got, again, a female that's got an orientation that's different and they're going through some hormone changes synthetically, then you would document that as well. All right, urethral orifice is above the vaginal opening. Close or slightly within the vaginal introitus. I don't really ever use these specific terms. I'm always just like external genitalia, throughout labia and vaginal walls, all look good. Okay. All right. Maybe thin or a large orifice. Again, the muscle tension. Just listen to your patients, and if you need to test that out with a finger before you use the speculum, that's appropriate. Same again, swelling, discharge, rashes. Skiing glands, I've never drained these on a female either, or even tried to during my vaginal exam. If they're complaining of something hurting, that's when I'll palpate and push around on the area that they're complaining that it's hurting at. And then I might specifically name these structures, but otherwise, in a normal female examination, I'm not going to name every anatomical structure. Bartholin's gland, those are more commonly getting abscessed, so just know that if you're encountering that you're documenting when you are incising and draining that, you're follow up very closely and documenting the anatomy surrounding that area. This is a picture of a Bartholin's abscess. So again, it's on the inferior portion of either, because you've got them on both sides, either wall of the vaginal opening. And the Bartholin's gland is what helps produce some of the lubrication that we need. Perineum, we've already talked about this, so when you are palpating and doing your vaginal exam, you're not only checking for cervical tenderness, size, the size of the uterus, and then both adnexal areas, trying to bring the ovaries to your hand, which is very hard to do. Almost always you will never be able to really palpate ovaries. If you do, then that's abnormal and you should ultrasound them. Or if they're having so much pain that you can't even get it to your finger, then you should probably just ultrasound them as well. Because either they've got ovarian cysts or a possible tubal pregnancy if they missed a period. So just do further workup if you're not able to literally finish out that exam. The perineum should be smooth, so when you are doing your pelvic and palpating the cervix, I usually go in, grab with my fingers, go poke this way, and then I'll run my fingers around the cervix. This is, of course, after your speculum, so after you've already looked. I'm still feeling, because sometimes they'll have a deep mass or bump that you can't see on the surface. Feeling that cervical motion, and then I'm going adnexal area, trying to pull in the ovary, adnexal area, pull in, and then also the size of the uterus. Then before I pull my fingers out, I'm feeling this side wall, and then I'm going down below and doing this number all the way out. So that you can make sure that that perineal floor has good stability, especially if they've had babies. If they've got scar tissue or extra flaps, because some people don't know how to sew after you've had a baby. Sometimes there's like cavities because they've sewn extra here but not all the way up into here, and you want to make sure that there's not a fissure that's being developed or even going down into the rectum. So that's why you're following that pelvic floor. It's kind of important to make sure that that's normal. The other thing is why I do that. If my female is not complaining of any rectal problems or passing of stool, I don't do a rectal exam. But if I feel something that's unusual that is not similar to what poop should feel like in that vault, then I'm going to do a rectal exam. As well as if that pelvic floor has some inconsistency and a possible fissure, then I am keeping my hand that already has the glove in here, and you've got a glove on this one, so then you ask your nurse, can I have some KY? I'm going to insert my finger into your rectum so that I can feel the wall, that skin on both sides, and make sure it's not communicating, and make sure there's not anything underneath there. Because if I feel a mass that doesn't feel like stool, that's what I'm feeling at. Yeah.
I'm just gonna ask the class, at what age would you start doing a rectal as part of a general physical and pelvic exam on female?
Yes. 50.
Right, so 50 years old, do it, because you want to guaiac the stool. And now you're screening for colon cancer. You wouldn't do it just to do it. And at age 50, if you haven't had a colonoscopy, just do a quick guaiac. I mean, that's easy. You're already there. The GIPA would say, please,
Yes, please do it.
do that.
So again, I am a practitioner that's coming from the ER. I did only actually a year and a half of primary care before I went into emergency medicine. So in the emergency room, unless they had a complaint, I wasn't going into the rectum, or unless they had a neurological problem. So again, it's going off of what you are doing. If you're doing an annual and it's a 50-year-old, because I've never done an annual on a 50 because I didn't practice that, then you would be doing that rectal exam. If they also have a family history of colon cancer, so like my aunt, on my dad's side, my grandfather had colon cancer, and they had their first rectal exam and colonoscopy at 40. I don't know what the guidelines are now. Is it 40? Okay. I'm stepping myself. All right, so again, you're thinking of inflammation, fistulas, lesions, growths. This is what vaginal candidiasis may look like. It's not always going to look the same, but see how that's thick? It's not going to look like the thick stuff that's on thrush on kids' mouth, but the discharge is thicker. That doesn't look like cottage cheese to me. It just looks like really thick.
Give it another day, it'll be cottage.
That is what it looks like to me. Come on, just make my eyes. All right, so do you all see the cervical os there? How would you describe that cervical os? So is that person, is that female, I know it's female, had a baby or not?
No.
It looks like it's at least had one baby. It looks like a slip to me. Almost like this one without the polyp. But obviously it's hard to see, so you would use an OB swab, clean it off to get a better picture of it. All right. I think I've already talked about all of this. So your anal surface is darkly pigmented. Vaginal surfaces as well are going to change color. So if you've got a female that comes in and they're getting older and they're like, it's changing color down there, is that normal? That is a normal variation of the skin tissue as you age. So your pubic hair will change color as you age, and so will the internal vaginal skin layers. And it also goes off of ethnicity too. So obviously, different tones of skin is going to have different pigment changes. We'll be noting scarring. So if they've had an episiotomy or a tear and you feel that, then you will note it. Skin tags, that's what I was telling about, extra flaps of skin in there can be developed in the vaginal vault as well. Obviously, we're talking about the anus, so you can also have them in the anal area. And then when you are checking a patient for hemorrhoids, you're going to have to differentiate whether it's an internal and external hemorrhoid. I'm skipping ahead. I've got a slide that shows that here in a minute. So again, we've already talked about how to use the speculum. So study your type of speculum that you're using. If it's metal, warm it up because those things are frigid. The plastic ones usually aren't as cold. Some people still warm it up under the water. I never warm them up. I put the light on as they're changing, and that usually heats it up enough. It's not going to melt it. Don't leave the light on and leave it in the drawer. Never had one melt, but I always worry about that. All right. There's the picture, metal versus plastic. Oh, no, both of those are metal. That is plastic? I've never seen a plastic one with a screw thing on it. Just a different variation. So obviously, this is the one I'm familiar with. The little green thing changes colors according to the size. So that'll help you to grab the right one immediately instead of having to study the size. But that's the little light thing that goes up under within that. And then that is the one that opens the duckbill and then also slides this way. That's my favorite one to use. And probably to have these. All right, we've already talked about this. Applying pressure downward, tilting it downward, and then consciously asking her just to relax. If you see that she's holding her breath, she's not relaxing. So Just breathe through it. They don't have to do the Lamaze breathing, but just making sure she's breathing. You don't want her having a stroke either. We've already talked about all of this. So slowly inserting the speculum in a downward motion and then opening it. Tell them it's going to clip, and I actually show the patients it's going to clip because that scares the dickens out of them too. They're like thinking you're going to cut them for some reason. I don't know. But. All right. Avoid touching the clitoris. You're really not ever up there with your hands. I use my hands to spread the labia, and then when you're inserting, I don't really ever, not really up there. But, oh, I'd never thought of
I
that.
remember Dr. McNeil teaching that, like, keep your thumb out of the way,
Yeah.
especially when you're on your bimanual.
So when you're doing your bimanual, yeah, tuck your thumb. You don't want to do that. That's not feasible. So, tuck your thumb. The other thing is that, you know, when you're going this way and this way, to me, it's easier to palpate a left ovary than a right one because I'm right-handed, and it's just this angle and my fingers are in the way.
And your fingernails need to be short. You know, you cannot have long nails.
You can't feel anything at the tip of your fingers if your fingernails are long. I already talked about this. So making sure that when you do insert the speculum, again, I'm going in a downward motion and you're inserting it all the way. Then I'm turning it and then I'm lifting up and looking at the same time. So if you're barely in there and you open that, that's where those muscles are. You're going to cause a lot of pain and you're not ever going to see anything. So make sure it's all the way in there.
No one ever explained this until I figured this out on my own too, but you know, your uterus it's kind of tilted like that, so you're kind of using the top of the speculum and the bottom to kind of lift the cervix into position so you can see it. Because most of the time it's going to be like that. So you're just kind of catching it and you're kind of lifting it up, and then you kind of shimmy it a little bit to get it around.
It miraculously falls
It'll
into
come
place
up.
because this bill, as you can see, is longer than this one.
That's the typical way it's going to be. Now, sometimes you'll have a cervix that's off,
the side.
you know, but
Then you're going to go.
most of the time, as you open it, it's going to bring it into so you can see it.
And that's when you're going to notate, because you're going to know before you even start using bimanually how that cervix was tilted. So was it retro? Was it left or right?
Another reason too to go position it at an angle going downwards, you want to stay off the urethra.
Yeah.
That does not feel good for somebody to ram speculum onto the urethra. If you've ever had a catheter put in, you know. So that's another reason why. Keep it on the down of the
On the down low.
You need to
So that
see
you're not
the
over
urethra before you put the speculum.
Don't do it blindly. Open your eyes, see what you're doing.
Stay off the urethra. Close it before you pull the house.
Lots of things to remember. They're like, oh, I think it is. You'll remember it all. Just think of what you would do for you. All right.
Don't pinch the vagina.
This is what we're talking about. So notate whether it points anteriorly, retroverted, posteriorly, laterally to the left, to the right, so on and so forth. As far as, I use the word laterally, they're using horizontally. So either one is appropriate. So I don't know why it says the cervix should be midline. It's not, very rarely is it like right there. That's all, in a perfect world. But again, it should be fairly, you shouldn't have to like be in the vaginal vault and then have to like go way over here. Otherwise, that is being pushed by a mass or something. I mean, it's going to be in that vicinity to where if it's not right there, you're just going to have to look a little bit to either side.
Well, and the other
But
thing
not
on that
way
too,
over.
Pearl, is You know, the vagina lengthens when you have sexual intercourse, but when you're just laying there getting your pelvic exam, it's not that long. So you could actually go past the cervix.
Yeah.
And then be trying to open up your speculum, and the cervix is like that. So you're trying to, you're like caught below or above it, which most of the time you would probably be above it.
A lot of the times you're up here.
And then you're trying to open your speculum and there's nothing there. Pull it out a little bit.
And then
Pull it back. And
so the
open it.
beauty of this being clear, is another reason why, look, use it as a window. Is it below? Is it above?
If you bury that thing and you go whack and open it up, there's no telling where you're gonna be. So,
That patient's gonna be
you
on the
wanna
ceiling.
kind of look as you're doing that and,
Yeah. So once you open it, once you open it, if you're not in plain sight or it's just a little over on one side or the other, then I am literally pulling it back down and pulling back out and then tilting more and going again. And then I'm looking as I'm opening. So am I looking? Is it on the top? Because if I'm tilting down there, since I've started doing it that way, I've never been under top of one. But that was very, very common when I was very first doing them, as well as the fact that these didn't exist when I was very first practicing. You can't see through metal. So these are wonderful. Superman? Okay, so here's the positions. Again, so if you were describing, your hand is gonna go over that pubic symphysis, which is the bone there. And again, a uterus is very, very hard to palpate, but you'll be able to feel something, and your fingers are completely inserted, feel something kind of barely touch your hands, and then as you're barely touching that, you're gonna feel it move against your fingers, so then you know that's the structure. So this is here, and you're pushing down, and as I push and encounter, I move this, and then it moves here, because it's all one unit. So that's how you know, yes, I'm touching uterus, and now how far is that between my fingers? Is that a normal size? Is it enlarged? Is it something I need to worry about? Where am I feeling it? Where did I have to find it? I, not knowing, as far as not practicing OB-GYN for very long, I would not be able to palpate a uterus and be able to tell you how it's shaped in their body, because I've not had that experience. I'd be able to tell you whether or not I encountered it, and if I saw it, whether it was to the right or the left or up and down. But
it's only gonna work in 10 patients.
yeah, which is rare in Black America. So the thin ones, and again, it's right above and below. You're literally going to hit the pubic bone and have to dig down and push this way. Because unless they're pregnant, it's not really going to be above that pubic bone. Or a mass or fibroids that's making it enlarged. So if you feel it above the pubic bone and their pregnancy test is negative, then you need to be doing an ultrasound anyways to find out why are we enlarged. I'm sorry, I didn't give you guys a break. I'm horrible about that. You guys need a break. Where am I on this anyways? The rest of these are going to go fairly quickly because the rest is just show and tell as far as bad, ugly pictures. You want me to keep going?
Sure. Yep.
All right. Color, you're going to note the coloration of the cervix itself. I don't know how to make it go back, sorry. So is it pink? Is it bluish? When it is starting to be blue or purplish, it's because of the vascularity. It's getting more blood supply. When somebody is pregnant, you have more vascularity. And so that's one thing that we call the Chadwick's sign. So if you open that up and you see the cervix is blue or purple, don't think, oh my gosh, it's decayed. It's because they've got a lot of blood supply to that area. It is also, when you've got that, it's going to be very, very friable, which means it's going to bleed easily. So you need to be very, very delicate with that speculum. The other thing is they are pregnant, and you don't want to do any trauma or anything to that cervix to cause it to be irritated and start dilating and causing them to go into preterm labor. So, usually if they didn't know they were pregnant and they're complaining of abdominal pain and you hadn't gotten your pregnancy test back yet, and you go to do your pelvic and you open it up and it's blue, you're like, I'm like, they're pregnant. You're really not going to manipulate it a whole lot. You're going to make sure they don't have an STD, because you need to treat that. And get your swabs if you need, but you're not going to really do a pap if you're in the ER. If you're in primary care, you will, because you need that as far as your first OB encounter, unless you are not doing OB care. So it all depends on what setting you're going to be practicing in. But don't be scared of it if it's blue or purple. It just probably means they're pregnant. Friable, that's what that means, is that if you touch it, it's going to bleed because of the vascularity. Surface characteristics, so that you're going to notate whether it's smooth, whether there are, looks like little pimples or clear vesicles. Most commonly are Nabothian cysts. Those are benign, not cancerous, not anything to worry about. They're not going to cause bleeding, but sometimes it is like a pimple, and there'll be a little bit of white pustular, like visibility. So note the color on that. And then discharge. When you note discharge, you document whether it is pelvic floor discharge, whether it is cervical discharge, if it's coming out of the cervical os, or if it's just within the vaginal canal. We've already talked about the consistency of it. And then your size and shape of the cervix itself. So nulliparous is a person that's never been pregnant, and it is a cervical os. Pretty much. This is kind of oval, but I guess that's as close as you can get. This one as well, but that one's got a polyp on it. And then once you've had a baby, it's more of a slant, like this. So, and it's called multiparous, regardless if they've had one or more than one baby, because you can't tell just by looking at it how many they've had. This is a dilated cervix, so it's just a nulliparous cervical os, but it's also dilated, which is a problem if they're early in their pregnancy. So notating whether it's multiparity or nulliparity, or nulliparous, or nulliparous, or multiparous. Man, I can't speak today. All right, we've already talked about all that. There's pictures of the variations, but we have had the models as well. The one over bottom left-hand side, again, that's not showing a blue purplish one, but it is showing the inflammation. Before, when you were pregnant, you would have inflammation. If they did your first pap, a lot of the times they were calling those pap smears abnormal, and then they realized that all cervixes change when you get pregnant, so it was no longer an abnormal pap. There's, so you see the huge variation in the color between the one on the right and the left. So the one on the right has a purplish hue. That is a pregnant female. Now, the cervical os is full of a mucus plug. That's what that is that you're seeing. It just looks like a water white snot. And then the other one is showing cervical polyp. So the variation in the color coming from the cervical os, again, I can't tell whether that is a nulliparous or a multiparous cervical os on the one with the polyp, because the polyp's in my way. It looks like the pregnant cervix, it looks like she's already had a baby, but again, she might just be dilated. The speculum is also pushing on that cervical os, so it might be just changing the anatomy because it's pushing on it. So just be careful. That's probably going to cause bleeding. And just tell your patients, I just did pelvic using the speculum. You're pregnant, and so you've got a lot of vascularity, and it bled a little, and so you're probably going to spot for a few hours, and that's okay. It's not meaning you're having a miscarriage just because I manipulated you. Make sure you give them that expectation of self-freak out.
I've lost babies.
All right, so as far as your pap smear, these are the different brushes. I don't do GYN. Do you know, is somebody going to give you specifics on when to use the specific type of brush, or, because I don't know anymore. The old fashioned was the
Whatever the nurse hands you.
stick, whatever they have. So it's,
Get some for psychology.
so it probably depends on how much money your clinic has or how much money they want to spend. So A is literally like a tongue depressor. It's wooden. The longer portion of that wrench-looking thing the smaller portion goes into the cervical os so that the bigger portion of the wrench can go all the way around and collect the cells on the outside.
Professor Brooks is ran to the STD.
B is just a brush. That one is, so when you do the spatula, which is what I call the wooden one, and the brush, not the bristle brush, the brush, you're going to use that brush and you're going to go not only into cervical, but then also brush that around the external portion. And this one I don't like because you're mixing those, and then when you slide it on a slide, I'm sure the pathologist can differentiate them, but I'm sure it's a mess compared to the other where they can take them from specific areas. So C is my favorite, obviously, but it's going to be the most expensive. You stick the pointed part of the brush into the cervical os, and then the other brushes just sweep the cervix on the outside. You don't have to push on that one as hard, and you don't have to twirl it as many times because 180 goes all the way around since it's on both sides. You've got it all. The other thing that I like about that is that you don't have to slide it on a slide and put the fixative and put it in the, you have so many steps to get that right to be able to get an adequate specimen sent to the lab, whereas you get that brush, the white part versus the blue part, the white part just, you stick your finger and it pops off and goes into the container with the fixative, put the lid on it and go. So much easier, less mess. More comfortable on the patient because they literally can feel that spatula stick. Yeah. B, you literally have to slide that on. The spatula, you just smeared it. I'm sure pathologists don't like the others either. This kind of goes through the details of. That's it. This slide just says what I've already said. If they have bleeding during the specimen, make sure you tell them, I caused you to bleed a little bit. You have a friable cervix. That doesn't mean you're abnormal, it's just more vascularity. People that aren't pregnant sometimes have a lot of bleeding as well. They just have a more friable cervix. So just let them know to expect some spotting. And then if they are having symptoms or their discharge is suspicious of chlamydia or gonorrhea, then you're going to get those specimens at the same time.
That's just a good old long Q-tip.
The gonorrhea one actually has to go into cervically, into the cervical os, and you have to twirl it 1, 2, 3, 4, 5. It's in the rear, it'll give you instructions. But now, gonorrhea and chlamydia can be both done on urine. It's just more expensive as well. So it depends on what type of your patient, demographics are, and what clinic you have, as well as the specimen containers and capabilities. So know that before you go in. This is just more pictures of the positioning of your hand. That first picture, again, is using their fingers. Like I said, I've only done that one time, and that was this year on a Good Shepherd patient. So I've been practicing now going on 20 years, and I've only done it once. But all my stuff's been ER. I guess I shouldn't say I've been doing public exams for 20 years. The rest of that just shows you the position of the speculum internally as well as the swabbing. we've already talked about feeling the size and the length and the shape of the cervix as well as the uterus. And then I always do everything, talk to my patient about, does that hurt? If it does hurt, is it a cramp? Is it a sharp pain? And then when I'm completely done, give them tissues, walk out, let them get dressed, and then come in and explain everything to them and answer any of their questions. I don't talk to my patient when they're sitting there with all that goopy gunk and uncomfortable. If your ovaries are palpable, should feel firm, smooth, and 3 by 2 by 1. Very, very small. Again, positioning of your fingers, and in hopes that you will be able to feel ovaries. This is literally telling you step by step the introduction of the speculum and your fingers. And then again, that second to the last bullet point, if you palpate something abnormal in the vaginal floor, just make sure that you explore it even further. Doing a full rectal exam with the other hand, or even using your dominant hand if you need. And then anytime you go within the rectal vault, you've already obtained enough specimen to be able to do an occult, so use that. Even if you can see or not see stool or blood on your finger, swipe it on an occult slide and test it. Don't waste that opportunity. This one just gives you more details. It says, with a digital rectal exam, when you're going in and feeling all of the sides of the walls of the rectum, and then also if they're complaining of hemorrhoids, if they've got external, it's going to be something that you can feel or see externally and feel right as you're introducing your finger. Internally, it's going to be way up in there, almost to where you can't reach. And then also noting the tone of that sphincter. Because the tone may vary, especially if they've had a tear up top that wasn't repaired right, or have a fissure, then that tone is going to be looser. Or if they're having incontinence, you can determine, do we have a neurological problem, and what part of the rectum is it affecting, so then you can communicate with that neurologist. It's the superior aspect of the rectal. External anal sphincter, EAS, that's the appropriate term to use. All right, and then after you're palpating that and seeing the tone, then you actually have the patient bear down like they're having a bowel movement. And that will literally relax those muscles and then come back down, and you can see if that coming back down is congruent throughout, or if it's you're just feeling it come up from the bottom or from the top. And again, you're just doing that if they're complaining of bowel incontinence or hemorrhoids or some major bleeding, or feel like that they're getting stool in their vaginal vault and they don't know how. Another picture of the anatomy. The one on the right actually shows you the anatomy of internal versus external hemorrhoids. And then here's some pretty pictures. So the one over on the left is, see the floor of the vagina where it reaches and meets the anus, which is your perineum. See how it's just all looks like hamburger mush? That is a patient that has had a tear that wasn't repaired correctly, and so then that's just loose tissue. And so if you were to think about it, when they have a bowel movement, that top part of her anal sphincter is not contracting and helping to move that stool. And so then the stool is probably pushing up into the vaginal canal, causing her to have to bear down more, or even digitally use her fingers to get that to come out, because the top portion of her anal sphincter isn't working. So she was having to create something synthetic to get it to clear that vault. The second one, dovetail sign, again, that's just some dysfunction of the top portion of that anal sphincter. That could have been a partial tear, or one that was healed but not sewn correctly. So it looks like it kind of curves over to her left. And then the last one, when they bear down and they're getting something protruding from their rectum, or rectocele. That's actually her rectum turning inside out. People that do dead weightlifting have that problem a lot. Men,
That's a rectal prolapse. That's a rectal.
not a rectocele, I'm sorry.
Yeah,
I
so,
did get that wrong. Rectal prolapse is coming through, a rectocele is the rectum coming out of the vagina.
yeah,
Sorry, I did that wrong.
rectocele is the rectum falls into the vagina.
I have a picture of that.
Yeah, but that's a rectal prolapse.
Those are STDs. I will rename that. Sorry. Endometriosis, you're going to have a lot of women that just have non-specific abdominal pain that you cannot figure anything out. And the only way to definitively diagnose that is for them to literally do a biopsy of the endometrium tissue to diagnose that. So a lot of your females will say, I've had a laparoscopic procedure which diagnosed their endometriosis and then treat it from that way. Lesions from STDs, so your condyloma cuminatum are genital warts. Condyloma latum is syphilis, and then you've got the chancre. Chancres are painless with primary syphilis, and then herpes is painful. Very vesicular ulcers. And then pictures here. So a chancre of syphilis is to the far left. Both of these are on a female. Obviously that second one being condyloma are just everywhere. These are horrible cases. They're not always going to be that fulminant or that advanced. So herpes simplex virus 1 and 2. Used to be 1 was above the belt, 2 was below the belt. You can actually have both in both areas now because of oral sex and the transmission of that. So you just have to do the blood test to determine whether it's 1 or 2 regardless of the site of the area that it is occurring in. Very, very painful, obviously. Okay, so condyloma, you can see this picture of condyloma as external genitalia. Condyloma cuminatum, and that's caused by, both of those are caused by HPV. This is the condyloma on the cervix, so the appearance is different because now you're in a moist environment. So now it looks white in appearance. And then you've got HPV causing squamous cell carcinoma. So again, different variations of appearances. The one with the squamous cell looks more of a silverish hue to that. So then we've got the other STDs, and you'll get this in infectious disease, but these are all the different things that you could be testing for in the common STIs. So trichomonas causes a frothy green discharge. But most notably, and on your boards, if they say strawberry cervix, then it's trick. They can be diagnosed by microscopy. A lot of clinics don't use the microscope anymore, we just send it off. Bacterial vaginosis, again, by ZV. I explain to my patients, you always have yeast and bacterial vaginosis. This is not an STI, even though it's taught in this area. That's normal flora that's in the vagina. And when the yeast goes down, then the bacteria take over and have a party and cause all the symptoms of bacterial vaginosis. You have an antibiotic to stop the bacterial vaginosis, or because you've had other types of infection, and then the bacteria gets killed down, so then the yeast take over and they have the house to themselves and they have a party and you end up with a yeast infection. That's how I explain it to my patients. We've got to get that back into balance. It's not anything that you did wrong, and you did not get it from your partner because he does not have a vagina. That's how I explain it to them, and then they calm down. And this is what each of them look like on the microscope. The top picture, that is the strawberry cervix with trich. Gonorrhea and chlamydia, so this is usually a vaginal discharge that is yellow or green or both. Very purulent, copious, which means quite a bit of an amount. And then you can actually see it coming from the cervical os if you do your pelvic exam with a speculum. The specimens used to be only by a brush that you had to do into the cervical os. Now you can do it by urine, which has been a wonderful invention as well. Because now the men will come and be treated. They don't have to have a stick up into the urethra. It was never pleasant. So chlamydia is the most common STI, and they may be asymptomatic for quite some time, or they could have very significant pelvic inflammatory symptoms. So either way. Here's your pelvic organ prolapse. So it can prolapse either way. So if it's coming from the anterior wall, which would be superior on your anatomy within the vagina coming from the top, then most commonly it's your bladder coming down into the vaginal bulb. If it's the posterior wall being prolapsed coming up from the floor of the vagina, then that's the rectum coming up through that wall. And then in the middle, you'll see the cervix coming down. It's not always going to be severe. I have had a patient in the ER when I was actually only 2 years into emergency medicine, where when I looked, she was like, something's coming out of my vagina, and she was really old, so I knew it wasn't a baby. And when I looked, I was like, that's her cervix. What the hell is that? I didn't remember this lecture. And so then I was like, what do I do with that? It scares the crap out of you. But it can be so severe that their cervix is literally hanging out. And here's pictures of that. So there's the bladder coming down, being a cystocele. The second picture being the cervix literally coming out. And then, yeah. And then the first thing that the surgeon, when I called him on the phone, he said, well, can you reduce it? And I'm like, what do you mean? He was like, can you push it back up in there? And I'm like, I didn't try, I didn't know what I was supposed to do. So obviously you're supposed to try to reduce it so they don't have incarceration of the vascularity. As well as with that hanging out, it's drying out, it's not in the area and the environment it needs to
My
be in.
instinct is to shove that back there.
Yeah, but then I was just like, I don't know if I'm going to hurt her more.
It's like if you have a finger that's crooked, my instinct is to put it back.
I saw a picture that said, this will scare your students of reducing that cervix. So it literally showed and then the way the uterus, because it's like turned inside out when that cervix is all the way out like that. So it showed the hand pushing the cervix and the uterus doing this, and then them shoving their hand, literally their fist. And I was like, yeah, call the surgeon, I'm not doing that. I'm sure it's not going to stay.
Well, that's your homework for tonight.
Yeah.
YouTube that. Reducing a cervical prolapse.
Here's some other wonderful pictures. So this is literally the bladder and the uterus hanging out, because I guess the bladder wall, the bladder's here and that wall is connected, the folds then goes into the uterus. So then the bladder fell down and started coming out and then pulled the uterus out as well. And so it's all out. I was like,
And again, back to that slide that's a prolapse. A rectal prolapse comes out of the anus. A rectocele can prolapse bad enough that it comes out of the vagina. So if it's a rectocele, it's going to come out of the vagina. Or if it's a cystocele, it's going to come out of the vagina. If it's prolapsing out of the anus, it's a
so
prolapse.
prolapse means it's coming out of the body, and the seal means it's just going into an area it's not supposed to be. That's how you
Does
should
that make
remember
sense?
that.
Everybody's confused about that?
Sorry, I labeled that wrong. Yeah, this is a rectocele, but then the thing that looked like a huge hemorrhoid was a rectal prolapse.
Prolapse. That's coming out of the rectum. It's not coming out of the vagina.
These are the symptoms that your female may come in complaining about, and then you would think, well, she's got some pelvic floor dysfunction and probably a prolapse. So sensation of vaginal fullness, pressure, heaviness, something falling out of me, or my insides are just coming out of me. Sitting like, feel like I'm sitting on a ball. sometimes, and I've literally had a patient say it feels like somebody has just shoved a broomstick up into my vagina and it just keeps causing sharp pains, like you're doing that repetitively. You're gonna get some weird complaints, but that was her complaint with this vaginal pelvic floor instability. Obviously, you've got stress incontinence, so when I sneeze or cough, I pee on myself, or I have stool incontinence when I cough or sneeze. And then back pain and pelvic pain, because of the way the nerves run, can refer pain to other areas. Incompletely emptying my bladder would be urinary incontinence, or just not voiding completely. And then urinary frequency and hesitancy because of the way the anatomy is kind of kinks off that urethra. And then these are the different grades of pelvic organ prolapse. So whether it's above the hymen, at the level of the hymen, or coming outside beyond the hymen. And then those are your descents, and then you've got the total prolapse where they're coming completely out. And this is just a resource as far as that guideline that I gave you earlier that I said we need to know this graph and know those dates. All right, actually, I started late, so
You want a demo on that real quick, how to,
on this, yeah.
So, do you want to have this? I'm just getting Kate's
Again,
head.
the speculum, so that you can see. I don't know if you're going to see it better this way or that way.
It has
So I'm going to turn it this way slanted, just the way the
I
opening,
can hold it there,
and
I
then I'm
just
going to
didn't
tilt
know
it
if
down as well. And so you're introducing it this way. So you're going to have pressure with my top fingers. I didn't realize I did that until I just now did it. That I'm pushing down, because otherwise it's going to want to go this way. So pushing down, and that way it helps them to relax and you're not getting up into the areas that are going to cause a lot of pain up here. Once I'm completely introduced, and a lot of the times your limiting factor is going to be their leg, then rotate that and introduce it a little bit more as you're rotating it. Then once you're completely introduced, that's when you open. That's not giving at all. I need to force it. So I was completely underneath it, and then obviously if you're not able to open it up, then you might pull back and then open. Just be really, really careful with this when you use this so that we don't tear it up.
yeah, we borrowed this, mine's on back order. Mine's way fancier than this one too.
Yeah,
It's on back order, so when you guys come on Friday to practice, your fingernails have got to be trimmed. Okay? I mean, just so we're not tearing up the nursing school's stuff, because we are going to have you, do a bimanual exam, so.
So we're just using this in
For Friday, you're using a model. We'll have one room that has the breast models, one room for
So then the other thing, as far as your bimanual exam, again, you're going to use lubricant, and then you're using your long finger so that you can reach the longest, and your index finger, and then tucking these out of the way as much as you can. Using their body to help move your fingers as well. So you're going to literally be pushing up against their gluteus to move these fingers further. So you're introducing, and again, I do the same angle as my speculum. So I'm pushing downwards, not upwards. And then going down. And then once I'm fully in there and I can feel the cervix, then I literally open my fingers just like I do, grab the cervix, and then I usually will turn and try and move it this way.
cervix. It should be uncomfortable, but it shouldn't be extremely tender. So they call that the chandelier sign. And the patient goes to the goes for the chandelier when you move their cervix. They probably have the cervicitis.
This model, just when you practice on it, is very, very short. So just know, when you push on this tomorrow or Friday, this is not as realistic as it can be, because usually I'm having to push my hand into the patient like this to get the full extent to get to that cervix to be able to feel the top of that uterus. Okay. And then I put my fingers together. Once I do that full motion, put them together again, and then pull back and move to the side so that I'm not scraping or pushing their
Again,
cervix.
short nails.
So pull back a little bit, and then again, fingers as lax as you can, and pushing as hard as I can, and then pulling.
And I don't
This
know-
is way easier than reality. You're never gonna be able to feel the ovaries like that.
So
This
you
is
can- okay,
I
so,
can really
and I don't know, it wasn't really clear in the lecture, so when you're trying to palpate ovaries, you find the cervix first, like she said, you can kind of feel around the cervix, but then you're putting your fingers to each side of the cervix and just trying to go as far up there as you can while pushing down from on top. And you do that on each side.
I
And
don't
really,
turn my fingers.
most
so
of the
I'm
time,
just
you're
saying
not
if it
going
was
to
easier,
feel
I guess.
anything. You're not gonna, you're not gonna feel anything. It's like palpating a kidney. If you're palpating a kidney,
And you feel it?
that's probably something wrong. So if you're palpating an ovary as an inexperienced student or PA, you probably want to get an ultrasound because you're feeling something that shouldn't be there. Does that make sense?
And I was wrong. You can feel the patient's right one much easier than their left, because this is going around a curve and trying to get up there. Plus, this finger's shorter, and I can't I don't turn my fingers. I just now did to see if I could feel this one because I wasn't a real patient, and I still couldn't feel that ovary over there. So, similar. And then, of course, when you're done with that next area, then you're flattening out your fingers and sweeping the rectal floor or the vaginal floor. Oh, I just
And when you're checking, like if you're checking for a rectocele, sorry, if you're checking for a rectocele or checking for a cystocele, your fingers will literally just kind of, it'll just kind of, I always say, it describes it just kind of falls into the rectum. If they have a rectocele, you'll just be, you'll be feeling the vaginal wall and it'll just like dive down because the vagina is kind of falling into the rectum, or vice versa for the cystocele on top. Always remember, cystocele will be on top, rectocele on top.
And as GI, so did you do a lot of that with the rectocele?
There's a lot of women with bowel